Okay, so we'll continue with the pain management part. Ideally, treatment is to remove the cause, but sometimes conditions are so painful that rapid and effective pain relief is essential. Examples: postoperative states, burns, and trauma. These conditions are so painful that rapidly pain relief is a must. Therefore, analgesic medications are first line, and all practitioners must be familiar with it. Classification: NSAIDs, opioids, anticonvulsants, and antidepressants. These are the four classes of uh, drugs which are useful for pain management. First is NSAIDs. So, NSAIDs are basically COX inhibitors, cyclooxygenase inhibitors, which leads to antipyretic effect, analgesic effect, and anti-inflammatory effect. Particularly effective for mild to moderate headache and musculoskeletal pain. So, we'll understand how this COX mechanism works. In our body, we have COX-1, which is constitutively present. That means it is already present. It is present in GI mucosa, platelets, and kidneys. It performs its function in these places. Whereas COX-2 is an inducible enzyme, meaning it will be induced in particular states such as pain, fever, inflammation. So we'll understand. Normally, our cell membrane is made up of phospholipids, right? Phospholipids, whenever cell membrane is injured, it is acted upon by phospholipase A2, which results in the formation of arachidonic acid. Arachidonic acid have a option. It can go into the COX pathway or as in the LOX pathway. Considering it goes into COX pathway, uh, uh, if it is COX-1, there will be formation of PGH2 that will ultimately form PGE2, I2, and thromboxane A2. These are all physiological prostaglandins. And if arachidonic acid goes via the LOX pathway, the lipoxygenase pathway, leukotrienes A4, B4, C4, D4, and E4 are formed. So we'll understand the basic functions. This, if we consider this as a physiological prostaglandin E2, it basically protects our GI mucosa, maintains the renal blood flow at afferent arterioles, and therefore it maintains the GFR, keeps the kidneys perfused in stressful conditions like shock, hypotension, CHF, circadian cirrhosis. As we all know, these are hypotensive conditions in which the renal blood flow reduces, and this prostaglandin E2 helps in maintaining the renal blood flow by dilating the afferent arterioles with the help of this prostaglandin E2. Then prostaglandin I2, which is also known as prostacyclin, is useful for vasodilation and antiplatelet effects. Thromboxane A2, which is present with the help of COX-1 in platelets, leads to platelet aggregation. Its function is to aggregate platelets. Okay. So now, arachidonic acid, when acted upon by COX-2, remember this was the enzyme which was induced in states such as pain, fever, and inflammation. Only that it is not normally present. It leads to the formation of inflammatory prostaglandin. This inflammatory PGE2 is different from the one we just read in the previous page. It leads to pain, fever, and inflammation. So whenever there is pain or fever or inflammation, this is the prostaglandin which is to be blamed. Okay. So these are the three mechanisms how this prostaglandin E2 basically leads to pain, to fever, and to inflammation. We'll see one of them. So whenever there is tissue injury, there are cytokines at that place, interleukin 1, TNF alpha, that induces cyclooxygenase 2, which ultimately produces this inflammatory prostaglandin, which binds to its receptor on the peripheral nerve terminals, increases the CMP, protein kinase activation is induced, phosphorylation, and pain receptors becomes hypersensitive, leading to pain. So this is the whole mechanism how prostaglandins are formed and how they actually lead to pain. Similarly with fever, whenever there is infection due to any organism, there is surge of cytokines, which this cytokines reaches the hypothalamus, induces COX-2, which leads to release of prostaglandin E2, which increases the set point in the hypothalamus and leads to fever. Same as with inflammation. Vascular endothelium induces COX-2 upon injury. inflammatory prostaglandin is formed, vascular smooth muscle is dilated, leading to leaking out of the fluid from the blood vessel, leading to edema and redness. So, this is the classification of our NSAIDs, in which it says this is the table from KD Tripathi. Non-selective COX inhibitors, that means these drugs are going to block COX-1 as well as COX-2 inhibitors, COX-2 enzyme. Preferential COX-2, that means they are going to block COX-2 more than COX-1. Selective COX-2 inhibitors mean they will only block COX-2 enzyme. Okay. Then there are analgesics with poor anti-inflammatory action. We know that paracetamol is the one of them. So we'll understand how aspirin exactly works. And also we must remember from here, like we have orthopedicians who prescribe selective COX-2 inhibitors such as etoricoxib and celecoxib, nimesulide. We must understand how these drugs are actually helpful for reducing pain. So as we knew that aspirin was a non-selective COX inhibitor, right? Non-selective meaning it will block either COX-2 and also COX-1 at higher doses, say 300 to 600 mg or greater than 1 gram. It strongly inhibits COX-2 enzyme. Therefore, it reduces the inflammatory prostaglandin E2 and therefore reduces pain, reduces fever, reduces inflammation. But this high dose of NSAID, this high dose of aspirin for a chronic duration, for a longer time, has its side effect with such as gastritis. This gastritis is so notorious that it can even lead to ulceration and even to perforation. Therefore, chronic use of high dose NSAIDs is a must know, and the person should be regularly checked and followed up for gastritis. The other complication with aspirin is nephrotoxicity. Okay, so as we have learned in our previous slide that prostaglandin E2 maintained our renal blood flow. Okay, and so it basically helped in dilating the afferent arteriole and maintaining the renal blood flow. But when you block prostaglandin production of prostaglandin E2, it doesn't allow the dilatation of afferent arteriole and hence can lead to nephrotoxicity, especially in conditions such as hypotension, CKD, cirrhosis. In those patients, never ever prescribe high dose NSAIDs. It can be nephrotoxic. And also, at the same time, if we prescribe aspirin at low dose, which preferentially blocks COX-1, COX-1 is present in platelets. It irreversibly acetylates the COX-1 that is present in platelets, leading to decrease in the production of thrombexin A2, which has antiplatelet effect. Therefore, in our coronary artery disease patients or anybody who has cardiovascular risk, we prescribe them on low dose aspirin, that is 75 mg to 150 mg, because it preferentially blocks COX-1 that has its major effect on thrombexin A2 only. This particular thing is not dealt with in low dose aspirin. This is the duality of aspirin. So this is the whole mechanism how membrane phospholipids with the help of phospholipase A2 gets broken down into arachidonic acid. Then uh, it goes into the cyclooxygenase and lipoxygenase pathways, and how leukotriene A4, B4, D4, and E4 are formed, how this H2 gives rise to G2I2 and thrombexin A2. This was the whole basic mechanism. So this was our first uh, uh, class, that was NSAIDs that we covered. Opioids. Now the next part is opioids. For opioids, we have some particular pertinent statements. That is, they are the most potent, most reliable, most effective, and physicians should not hesitate to use opioid analgesic in acute severe pain. But the doctors and the nursing staff are always in a dilemma whether they are going to sedate or uh, either the patient might go into respiratory depression. These are all the dilemmas because of which these opioids are not that commonly used in hospital settings. But respiratory depression is uncommon at standard analgesic doses. Hence, usage of opioids must be normalized, and it should be prescribed in standard analysis, and that we'll see in few more slides. So these are the examples of opioids analgesics. We have codeine, oxycodone, morphine, methadone, fentanyl, we have tramadol. These are all narcotic analgesics. As you guys must remember in our previous video in pain's pathophysiology, if you guys remember, pain modulating pathway acted via endogenous opioid molecules such as enkephalines, right? So there were mu receptors, opioid receptors, and these analgesics, these are opioid drugs which also acts on mu receptors only. Okay, so this is the table from Harrison's, giving its doses and intervals. So the side effects of opioids are dose dependent. Keep that in mind. The side effects of opioids are dose dependent, and whenever in hospital settings when higher doses of opioids are being used, we must keep naloxone with us, which neutralizes the effect of opioids. And also, never to prescribe or never to give opioids along with other CNS depressants such as benzodiazepines, because they cumulatively will increase the sedative effect, and the patient might land into respiratory depression. Opioids produce analgesia by action in CNS, mu receptors, inhibit pain transmission neuron. So this is the statement I liked from Harrison. That is the most common error made by physicians in managing severe pain with opioids is to prescribe an inadequate dose. Because many patients are reluctant to complain, this practice leads to needless suffering. Because the patient might not tell you always that he is still having pain, it is our duty to prescribe opioids at adequate doses and to follow up the patient whether there is pain relief or no. If not, we can also increase the dose. We'll see in few more slides. So there is one concept, that is patient controlled analgesia. Patient controlled analgesia uses a microprocessor controlled infusion device that can deliver a baseline continuous dose of an opioid drug as well as pre-programmed additional doses whenever the patient pushes a button. Basal bolus kind of a thing. There is continuous infusion of opioids being delivered to the patient, but if the patient experiences pain, he can push a button. The program is such that it will deliver a preset amount of uh, bolus dose of opioid. The patient can then titrate the dose to the optimal level. This approach is used most extensively for the management of post-operative pain, but there is no reason it should not be used for any hospitalized patient with persistent severe pain. So we must have a knowledge of patient-controlled analgesia. It is a good thing and it should be adopted. The second thing which I came across is the routes of administration. As the most potent route for giving opioids and having pain relief is intravenous route, but if we prescribe or we infuse via the spinal route, that is either in the epidural space or intrathecal space, the dosage of the opioid required will be much lesser. For example, morphine, if given via the spinal catheter into the epidural or the intrathecal space, will just be enough with the dose of zero point 0.1 mg, whereas if given otherwise it would require 3 mg to 5 mg dose. Hence, we must have a knowledge about other routes of administration which reduces the dosage required and have adequate response without having much side effects. Okay, there are spinal routes, intranasal route, rectal route, transdermal routes, and oral mucosas. As with opioids, the most common side effects are constipation, nausea, vomiting. Therefore, whenever using opioids as your analgesic of choice, we'll have LV-Mopen with our side because it is a peripheral antagonist of opioid. It reduces its peripheral side effects, therefore helpful in paralytic illness. The other is methyl naltrexone, again a peripheral antagonist, which reduces the constipation, which is a prime side effect of opioids. Okay, so this was our second class. Then there is a combination drug, which is opioid plus COX inhibitor. So that is NSAIDs plus opioids. This is also a good choice. For examples such as PCM plus tramadol combination. So Harrison divides the pain management part into two things: acute pain and chronic pain. So first, whatever we showed till now was with respect to acute pain management with NSAIDs or with opioids. For chronic pain, as we have seen old age gentlemen presenting with vague symptoms, in which the diagnose or the finding the cause of the pain is a pretty difficult task. In those conditions, we have different class of drugs, which we'll see in a few minutes. So the Harrison talks about the approach to how to recognize this chronic pain. So it says first, is there any disease currently present with the patient which is non-treatable? Either it can be arthritis, cancer, fibromyalgia, diabetic neuropathy with which the patient is suffering. That might be the cause of chronic pain. Or else the patient had a disease, it has resolved, but it still has some symptoms going on, and that the patient is complaining. It may be because of damaged sensory nerves, reflex muscle pain, contraction, spasm, etc. And the other thing is psychological factors. Now, this is how Harrison tells us to approach a patient with chronic pain. For chronic pain management, we have two classes of drugs majorly. The first is antidepressants. Yeah, you heard it right. Antidepressants. The mechanism stays unknown, but they are well known for their analgesic effects. Examples: classic tricyclic antidepressants such as amitriptyline, imipramine, nortriptyline. Non-tricyclic antidepressants, which are venlafaxine and duloxetine. And we must understand this: venlafaxine and duloxetine has supplanted this classical tricyclic antidepressant in aspect of analgesia. The second group is anticonvulsants, and the third group is chronic opioid analgesia, which is used for long-term malignant conditions. All right. So antidepressants. Antidepressants, they have dose-related biological activity. Mechanism is unknown how they produce pain relief. They're shown to potentiate opioid analgesic, therefore used as adjunct for chronic severe malignant pain. Okay, there are several side effects with respect to antidepressants: drowsiness, memory impairment, constipation, orthostatic hypotension, urinary retention. So, therefore, non-tricyclic antidepressants, that is serotonin norepinephrine reuptake inhibitors, which are venlafaxine and duloxetine, have replaced those classic tricyclic, and hence these things are used for chronic pain management. So these are the list of conditions in which we must prescribe this antidepressant drugs, and will have a excellent response, such as post-herpetic neuralgia, diabetic neuropathy, fibromyalgia, tension headache, migraine headache, rheumatoid arthritis, chronic low back pain, cancer, and central post-stroke pain. Okay. Anticonvulsant drugs, again, you heard it right. Anticonvulsant drugs used for pain relief, useful primarily for patients with neuropathic pain. Examples include phenytoin, carbamazepine, gabapentin, and pregabalin. These two drugs, which are newer calcium channel alpha 2 delta subunit ligands, they are used even as first line drugs for any neuropathic pain. So therefore, this is the last part in Harrison's. It talks about neuropathic pain. So it tells that directly don't jump into prescribing these drugs. If you suspect there is a post-herpetic neuralgia, as in herpes zoster, you prescribe 5% lidocaine transdermal patch. Okay, and then you prescribe the first line is anticonvulsants, like pregabalin or gabapentin, or you can write antidepressants, uh, venlafaxine or duloxetine. Opioids are considered to be second or third line. So in summary, we had acute pain management with NSAIDs on opioids, and with chronic pain, we had antidepressants and anticonvulsant drugs. Thank you.